All right, welcome everyone. I'm Sarah Alger, the director of the Russell Museum here at Mass General. Welcome to those in person and in Zoom land. Before I introduce tonight's speaker, I'm going to make a plug for our next few lectures. In April, we actually have two back-to-back. On the evening of Tuesday, April 8th, we have Jennifer Mulligan of the MGH Weight Management Center talking about the very latest into the research about the obesity drugs that we've heard so much about. The following day at noon, also here in the museum, we are celebrating National Poetry Month. It's the 7th annual celebration of Poetry Month here at MGH. And it's going to be sort of a combination of poetry and art and music, commemorating the 5th anniversary of COVID and the resilience that came out of it. And then Wednesday, May 28th in the evening, we're going to have Bruce Rosen on the past, present, and future of the Martinos Center for Biomedical Imaging here at MGH. And they do absolutely incredible things. So we're excited for that one as well. One housekeeping note to the Zoomers, there will be plenty of time for questions. At the end of Dr. Gordon's talk, just use the Q&A function in Zoom. And now to introduce our speaker. Dr. Gordon is the Vice President of Education and Chief Learning Officer here at Mass General, where he holds the David F. M. Brown, MD, Endowed Education Academy Chair, and he oversees the Peter L. Slavin, MD, Academy for Applied Learning in Healthcare. He is professor of medicine broadly and emergency medicine specifically at Harvard Medical School. After studying intellectual history at Princeton, he attended medical school at the University of Virginia and completed his training in emergency medicine at the University of Michigan. He then completed a fellowship in the Robert Wood Johnson Clinical Scholars Program, and he earned a master's degree in public administration at Michigan. He served as principal investigator and national co-chair of the first federally funded research consensus conference on simulation in healthcare, and was a founding board member of the International Society for Simulation in Healthcare, where he was later inducted as an inaugural fellow. And with that, let's welcome Dr. Gordon. Thank you.
Okay, well, it's nice to see everybody in person and online. This is going to be sort of a retrospective, shall we say, with an eye towards the future of educational technology as it's evolved in healthcare over the last, I would say, 25 years, and it focuses on simulation. In particular, we'll talk about what simulation is in healthcare. This is simulation in the health professions, medical simulation, nursing simulation. It's to replicate a patient encounter. And the premise that has underlied a lot of this work is that there's not many things that we know of that truly improve translational patient care outcomes. But we do know that if you practice, and if you practice together, and if you get feedback, and you can continue to experiment and refine your practice, just like everything else in life, if you practice a little more, you'll do a little better. And so in healthcare, it's been a journey to be able to understand those things that actually do impact patient care from an educational perspective. And so you'll hear me talk about both the history of education in healthcare a little bit, what simulation is, and then we'll go forward a little bit as to how it is that Mass General Hospital within the MGB system has begun to implement what is now understood as evidence-based interventions to be able to improve care from an educational perspective. And as always, I'm just delighted for any questions that people might have, either while I'm chatting or online. I suspect that Sarah or Michelle might be able to help us with any of that, but feel free to interrupt, of course. All right, any questions before we get started? Good. Let's see if I can make this work. Oops. Almost focus probably back on some of those. Now, great. Okay. So the first thing that's sometimes helpful is to understand definition of terms, right? So what is it when I say medical simulation or health profession simulation? What is it that I'm describing? And as you might imagine, there's lots of different ways that people have tried to replicate patient care over the years, ranging from hundreds of years ago, there would be a doll or there would be something else that would be used as an example for the patient. That goes back into many health traditions to be able to identify where something hurts or to be able to work on something that would be a doll or a mannequin. And some people would say that a really good lecture, especially ones that are animated, are good simulations. So that's not what we're going to talk about. We're going to talk about this concept that I've described in quotes here, which is technology enhanced medical simulation. And the kind of technology enhanced medical simulation that we're going to describe has been around probably since the mid to late 60s. So it's, 50 plus years that's been around. But in particular, the kinds of work that we're going to describe here have been around really for the last 30 plus years, but hasn't really been in place before then. The important concept of technology enhanced medical simulation that we'll talk about here, because lots of different kinds of simulation, is that it replicates the clinical encounter. And what that means is you're trying to simulate or replicate what it feels like to be able to see, talk to, examine, and understand a patient encounter. So this is not, when I say technology enhanced, it's not intended for you to be looking at a screen, right? Those are good simulations on a screen. But I'm not going to talk about that. I'm going to talk about a technology that allows you to actually do what you would do in the real world, which is walk in the room, say hello, ask a question, interview a patient. You can do all those virtually in a screen-based simulation, but what I'm going to focus on is actually replicating there's a bed in the room and a provider and a patient, and this simulator, right, is essentially going to look and feel like a patient. So many of you here may have seen what variously called high fidelity or other kinds of robotic simulators. And so in this particular case, for this talk, we're going to focus on robotic mannequin simulators. And these are almost like sophisticated CPR dummies that can talk and breathe and blink and move, and you can make it sweat and bleed and a whole variety of things. So think about this when I say technology enhanced medical education that replicates the clinical encounter. That is a humanoid robot that is animated and can talk back to you, and you can talk back to it. We found that some of the most important things in terms of the characteristics that allow people who are playing the role of a provider is it's really important that it blinks. It's really important that it talks. It's really important that the chest rises as if it's breathing. It's really important that you can touch it and you can feel feedback, i.e. you can feel a pulse sometimes. It's really important that it be a dynamic encounter. Sometimes people will try to pre-record what the patient will say. It becomes, and even some sophisticated systems will be sort of neural network feedback. But we've found it's really quite compelling to have those few humanistic things with a real voice that goes back and forth, which means that there's another human who is speaking into a microphone who is speaking for the patient. It's almost like a ventriloquist. And those very simple things become really important as we talk about sort of the theory as to why we think simulation is effective and why it's different from other kinds of activities. So now that we sort of have this notion of we're going to talk about robot mannequins that look and feel like patients and that providers and trainees can go into the room and practice. Even within that world, there are, as you can kind of see here, three different fields. Those fields can be research-based or practice-based, but I'll start with the earlier ones and progress to where we see them evolving over the course of the last few decades and where we're going to focus on in particular in this particular talk. So the first notion is a lot of this work started in the late 60s, early 70s, and into the 80s. The work was to be able to replicate what was happening in the operating room, because the operating room was viewed as a high stakes environment. And there were providers, anesthesiologists and others who were in the operating rooms, and they were also pilots. And they made the connection to say, well, gosh, the environment of the cockpit, a tightly controlled crew with a sophisticated activity, can be a lot like an operating room. And they began to apply these principles called crew or cockpit resource management to the operating room environment. Dave Gaba out of Stanford, one of the real founders of this work, with my good colleague Jeff Cooper, who's an emeritus professor here in anesthesiology at Harvard. And the two of them were really terrific mentors and leaders of this field moving forward, with a whole host of wonderful folks around the country and around the world. But it became initially a way to be able to think about how do teams work together to produce high performance in the middle of complex environments. And in the aviation world, pilots are required to be able to train in the airplane simulator, the flight simulator, at intervals that are then prescribed by their accrediting body. That's not the case in healthcare. And so one of the questions becomes, is that something that we should aspire to? And how has it worked out in the aviation world? And how does it apply to the world of medicine? And then, quite frankly, how do other corporations, businesses, entities work on team performance to be able to improve what the ultimate outcome of the product is, whether it's in manufacturing or whether it's in engineering or whether it's in military or aviation? So the first element here is cockpit or crisis resource management for communication behavior. We'll talk a little bit about that, and that's an entire field unto itself. But I want to move on to the next item, which is you would imagine that it makes sense that if the team communicates perfectly, except that the skill set technically that's required is missing from the group, it's very hard to get the task done. Everybody can talk about it, but they can't actually do it. And so our surgical and procedural colleagues have used simulation now over time to be able to train to do procedures, operative procedures, invasive procedures, do an operation, put in a stitch, be able to use an endoscope, things of that nature. And so the combination of those two things, as you might imagine, made perfect sense in an operating room environment, where there are both procedural elements to be completed as well as high stakes choreography of teams. And so that in and of itself is a whole nother world to be able to think about technical skills team and training alongside of team training. And this ranges all the way from what have been traditional modes of practice on a plastic dummy to be able to put in stitches, all the way through to a virtual reality environment where the holographic image now has what we call haptic or tactile feedback, right? You've seen in the movies, people are touching the images. This notion of being able to touch the image has always been an elusive goal, because so sophisticated to be able to replicate, and it's really important for people to feel and touch like it really feels. If it doesn't feel that way, it's not as instructive, but it's very attractive to be able to think about it. Those of you who are of my vintage may remember the holodeck, right? The holodeck is a room in Star Trek, not the very first 1960s Star Trek, and probably not even the 1970s, but somewhere in the 80s or 90s, the version of Star Trek on television was that because you're in the middle of the universe, in the middle of nowhere, it would be really great to have a room in which you can snap your fingers, tell the computer, I'd like to be on the beach in Jamaica, and the computer would then have holographic projections, and then there would be trees, but you could touch the tree, you could go into the water, right? So this became a very fanciful notion of, can technology really replicate the tactile and sensory environment in addition to just being visual? And that became a whole line of study as well. Very hard to be able to do that for tactile technical things. But more and more, if those of you who are not my vintage would be able to say that the most recent version of virtual reality, artificial reality, commercially available HoloLens or other kinds of things would be able to do this work and they've begun to make real progress on not only seeing in multiple dimensions, 3 dimensions, but also being able to grab something with your hands. Sometimes people will have gloves, and the gloves are then sensate that you can sort of electronically be able to move things. Okay, so those are two really impressive forms of simulation. And then I'm going to move on to item number 3, which is going to be what I'm mostly going to talk about here. So we're not going to talk as much about team training or as much about clinical or manual technical skills training, but of the concept of what it is to be a health provider, whether that's a doctor or a nurse or a pharmacist, an interventionalist, or a clinic-based environment. And what people typically want to understand is, can we have an environment that allows people to practice what it's like to be a doctor or a nurse or any other health professional, and to be able to approach the patient, talk to the patient, interview the patient, examine the patient, create data repositories, order tests, provide medications, think about what's wrong, talk to the patient about how it's going, talk to the family about how it's going, how to be able to deal with complications in therapy. And so this notion of being able to do the work that is intended to be a full caregiver is intended in this third bullet, which is thinking about critical thinking, cognitive skills, and evaluation. And this is what people normally would think of when you say, well, what do you go to nursing school or medical school or residency to do? And this is what you go there to do, is to learn how to be this kind of healthcare provider, whether you're a physician, a nurse, or other kind of practitioner. So it's this third area that we're going to spend a lot of time on. And so you see what I've defined as kind of 2 worlds. We're going to talk about robot simulators, and we're going to talk about robot simulators for a complete medical, surgical, or healthcare encounter. And then as we go on, we can talk more about that specifically. The last bullet here is just a nod to a more modern approach, which is if I can really replicate a healthcare environment with all kinds of tactile, sensate, visual cues, then maybe I can build the building better. I can build, the architects and engineers can put equipment in the right place versus a more complicated place. So there is a world of healthcare architecture, engineering that works really hard to be able to replicate what a building is going to look like before it's built, so that when it's built, you don't have to say, geez, how come they put the light here? They should have put the light here, right? And so you're trying to sort of figure that out ahead of time. And that's in a world called human factors and engineering, which is how do you set up the physical environment so that humans can interact with it in the most appropriate way. So the whole field of simulation is kind of wrapped up together in these kind of 4 worlds, and then we're going to talk mostly about critical thought and cognitive skills. Okay. So now that we've sort of identified what is the definition of terms here, what is it that we're talking about here? Animated robotic simulators that replicate healthcare encounters in their totality. That's what we're talking about. In particular, in order to teach people how to be able to practice the skills of being a caregiver before they get into the room, or as a way to practice. This is not dissimilar to any other field where people want to practice, right? So in healthcare, people use the word practice. It's a bit of a misnomer here because they say, well, I'm coming to work every day. I see lots of patients all the time. I'm learning every day. This is how I learn. So I don't need to take time away from the clinic or the unit to be able to learn more, because every day I'm learning all the time on the job. And that's not wrong, of course. That is true. That is what we do. However, it's also very well known in the field of human performance that just being, quote, on the line, it's a factory reference, doesn't give you the most advantages to learning and improving. And that's a very similar concept to what you'll see in popular culture, which is if you're going to be a good musician, you got to practice. You can't just show up to concerts a day. And even if you take the somewhat worn analogy of Tom Brady and say in his heyday, if Tom Brady just showed up on Sunday every day, meaning Sunday, but didn't come to practice, how would it go? Well, the answer is probably go okay, right? But you hear by intonation, yeah, it should be okay, right? Would it be as good as if he came to practice every week? It would not. Would they win, 6 Super Bowls, right? They probably would not. And so it's not that coming to work is not educational. It is. And most of the work that we do is highly educational. But it's very well known that if you want to perform at highest performance, at high reliability, without variability in a high-risk environment, the more practice you have, the more reliable and better you'll get. We'll talk a little bit about the evidence base for that, which makes this an exciting field because there's not too many things that we know will actually, if you implement them, they will improve the lives of other people in healthcare. Simulation happens to be one of those things, and we'll talk a little bit about the science behind that. I've been doing this kind of work for a long time, and so even before there was an evidence base for this, people would say, well, it's commonsensical. And I agree with that. It is commonsensical. But now we have something that's both commonsensical and scientifically proven. But in the commonsensical world, the question is, why should we 20, 30 years ago have spent time and energy on developing simulation tools when we have a good healthcare system in the United States compared to other places, and doctors and nurses and pharmacists and therapists, they practice really well, right? I mean, we're sort of lucky to be in the United States to receive care from folks who have trained so diligently. And at the same time, everybody wants to make sure that when they go in the hospital or when their family goes in the hospital, that they're going to receive high reliability care all the time, right? Because all of our loved ones are so important to us. And that should be the approach across the board. Now, if I talk to you about patient safety, it turns out that medical error still probably, I think the last I looked was, the third leading cause of death in the hospital. And that's been true for decades, ever since the Institute of Medicine began to study. And if I take my own emergency medicine practice, the medicine that I practice now compared to the medicine I would have practiced 25 years ago, it looks pretty similar, right? There's been improvements, and the quality and safety and the clinical teams have done lots of great work over the years. But if I asked you, is medical care 50% safer today than it was 30 years ago? It's not. And if you don't believe that's true, the most recent sort of data begins to suggest that because we live in a complex human system and we're complex humans with complex problems, and providers are complex individuals in a complex system, it's very hard to have very high reliability unless you practice, practice, practice. But when you practice, that means you're not seeing patients. It's one less operation. It's one less person who is caring for you in the ICU. So you see, we have a capacity issue in healthcare. We need as many providers to be working as much as they can to be able to provide great care. And at the same time, if you said, I need to take you out of care to be able to practice, well, that's hard because that means you have to change the schedule of providing the care that people need. So then the question becomes, can you identify? And the answer is we can't, but we would like to. Let's imagine I said that, okay, 99% of practice is going to be actual clinical practice. And that's going to be a lot of learning, most of your learning, 99% of your learning. But 1% of the time, we're going to take you out of the clinic and assign you to a training environment. And the theory here is that if you do 99% plus 1%, 99% of training plus 1% care. Now, remember, in most domains of expertise, that's flipped, right? You practice Monday, Tuesday, Wednesday, Thursday, Friday, Saturday for a game on Sunday. In medicine, we can't do that. We got people who we need to be able to provide the care. So I'm just touching the surface and I'm flipping it, right? Most of the time, you're going to be doing the line action, but a tiny little percentage, I'll just call it 1%. And then the hope is that you change the output from 100% to 103%, 105%, because you've learned so much in that 1% that's informed by your clinical practice that the entire system gets better. And so that's the premise of this work. Do we know that that is true? We don't know that evolution is, there's no, it's a bit of an experiment, shall we say. And so I'll show you the evidence of where we are to date and why it makes sense to believe that that's true. It's not just a wish. There's some good evidence to suggest that that's true, but it's going to take large systems to be able to invest and understand whether that really is the outcome that comes. And so we're delighted that at Mass General Hospital and across the Harvard MGP system, there's been many, many folks who've been working in the simulation field for now decades to be able to understand how this institution and these institutions can help to be able to understand if what I just described to you as a hypothesis, more simulation is better care, is really true in the way that I just described at scale. So it's made sense to say simulation is really important because it's a patient safety imperative, right? Nobody wants somebody to be doing this for the first time, or they only do it once in 10 years on you or your family. You want somebody who's practicing this all the time. And if they not have enough clinical volume, you want them to practice in realistic replication. The second item that makes sense for simulation is to think about, can you really deliver high reliability standardization of care and curricular training if you can't be in the hospital 24 hours a day, 7 days a week? And the answer is, well, you can't humanly be in the hospital 24 hours a day, 7 days a week, either to practice or to learn. And even in the more modern era, it used to be that people were working 100+ hours a week in the hospital because there was so much to learn and there was only a limited amount of time. And so the question becomes, how is it that you can learn the things you need to learn if you're not there all the time? Because that means if you're on overnight call as a trainee every third day, you'll miss on some of the patients who will come in. And your colleagues will see these patients, but you won't. You'll hear about them, but you won't actually take care of them. So what happens if you miss the case? And that's a rare enough case, you may not see it. So I'm curious as to how people think healthcare has solved this problem. So healthcare has solved this problem for about 50+ years, a very ingenious solution to mitigating the time and chance variability of clinical presentation. You can't always be in the hospital or the clinic all the time to see all the patients. So the question then is, how have we compensated for that to be able to make sure people see as many things as they need to see to be competent after they finish 3, 4, 5, 6, 7, 8 years of training? You can all just jump right in there. Yeah.
Records.
Yes, well, it's been case conferences and case records, and we go to lectures and we discuss cases. And at the same time, over many, many years, historically, we've simply expanded the length of time that trainees have to be present. So that if you think about 100 years ago, more than 100 years ago, but in the late 1800s and the early 1900s, if you you could apprentice with the local doctor or barber and go to a few lectures at the local school, and presto, you're a doctor. Then you just be a doctor. You put out a shingle, and that was good. And around the turn of the 20th century, it became clear as science was advancing in Europe and other parts of the world that that approach wasn't as good as, maybe you should really learn the science in university and then really get mentored in a university or a hospital setting. And that gave you better training. So it went from haphazard training to now you have to go to 4 years, right? 4 years of school. And people thought that just having those 2 years, half the time, first 2 years of medical school in the medical paradigm was classroom teaching. And the last 2 were clinical teaching, the whole package. So that was true, and that worked, I don't know, through World War I. And then as science began to grow and we learned a lot more about the world, people began to conceptualize what became in this country what was the gold standard for many years. 4 years of medical school, but those last 2 years of medical school weren't enough. It's too much going on. So you had to be an intern. And that meant that a year after you finished medical school, you were in the hospital, and you were in the hospital for 100+ hours because you needed to learn all that stuff. And then you could become a doctor. And it used to be that in many states around the country, going to 4 years of medical school, passing all your tests, and having a year of internship was the standard. In some states in the country, it's still nil the standard. You could go to 4 years of medical school, 1 year of internship. That makes some of us nervous because the modern approach to care these days is 1 year of internship is no longer enough. It's not been enough for a long time. But most general practitioners in the 40s, 50s, and 60s, that's what they did, right? They did 4 years of medical school and an internship. And so you went from haphazard training, and then you went to 4 years of medical school, then you went to 4 years of medical school plus an internship. And then somewhere, World War II-ish, right? It became, well, 1 year of internship wasn't enough because there's surgery and there's obstetrics and there's pediatrics and there's psychiatry. There's so much to learn. Okay, so then you specialized. And then okay, you said, okay, well, I'm going to do a year of surgical training, residency. And surgical residencies now range all the way up to postgraduate year 8, right? And so you started with haphazard 4 years, 4+1, 4+1. Oh, maybe a year of residency, maybe 2 years of residency, maybe 3 years. Oh, maybe 8 years of residency. Oh, and after residency, guess what? There's a fellowship. And the fellowships all started at 6 months, 1 year, 2 years, right? So now you're into the world of somebody's going to be 42 years old before they actually practice. And so it turns out that system actually worked really well until such time as you finally realize you just can't start practicing by the time you're 42. People have families and careers and take care of parents. And so you just can't do it anymore. It's not a critique of the old system. You might say the old system worked pretty well, but the old system needs a little help to be able to solve the problem. You can't solve the problem anymore by just taking more time. Okay. So now the question becomes, what do you do? Right? Because there's more and more information and there's not a whole lot of more time. So now the question is, can you accelerate the acquisition of expertise such that you get the same, if not more, information in a shorter amount of time? Huh. Well, that's interesting. And so are there technologies that allow us to do that? And so if you ask me, are there 3 problems in the history of health professions education that needed addressing in the pre-simulator world that we could never solve, that the simulator might help us to solve? 1, we haven't moved patient safety as much as we would like. Can practice help us? Yes. Can a simulator help us do that? It can. I want to be able to standardize the curriculum. If you didn't see the case last night, but you see it tomorrow in a simulated environment, is that better than never having seen it at all? It's better, but it's the way to mitigate this issue in a way that, oh, I just didn't see it. Is it better than an M&M case? It is. And we can talk about the evidence for that. Can it help people get to a certain place on their learning curve sooner rather than later? If I can replicate these things on demand, I can show you 15 heart attacks in the course of a half-a-day session, and it would take you 3 months or 3 years to learn that in the real world. I can. And the simulator technology, in the way that I described it to you, allows you to do that. That's different from other forms of simulator technology, which are still very good. I can watch 15 heart attacks on the screen, but that's not saying that I can take care of 15 heart attacks in the real world. But I can learn a lot. But could I do more by actually touching and feeling a simulator? You can. Okay. So this concept that we talked about in terms of deliberate practice. Deliberate practice is a term that's coined by Anders Ericsson, who's no longer with us. He was at the Florida State University and previously in Europe, and he was a behavioral psychologist who worked a lot on this notion that got incorporated into popular culture, which is, if you're going to be good at something, you got to do it like 10,000 hours of practice before you're really, really good. And everybody else is, you're okay, right? You're good, right? But you're just not as good as you really could be. Right, so this is where we get all kinds of teams that are practicing all the time. And industries, unlike healthcare, have been able to figure out how to incorporate this level of practice into their daily routines because it's well understood that productivity and efficiency and reliability and safety come from routine practice. But in the healthcare environment, we have this kind of paradox, which is that every time we take somebody out of the healthcare environment, it means that a patient's not going to get the care that they need. So we don't want that. So we have to figure out how to be able to do that and still be able to function. So you see the definition here of deliberate practice: training activities designed by a coach or teacher to improve aspects of performance through successive refinement. And it really has come to define the highest levels of individual and organizational excellence across multiple domains. And healthcare is a special case for the reason that I just described to you, which is taking people out of the clinical environment means that there's patients who might have less care in a system where we need all the capacity that we can get. So we're talk a little bit about some of the behavioral science as to why it is that we think simulation is better, different, or more unique than other forms of education, which I'm describing to you have been exceptionally successful. I mean, we've trained really good practitioners over a long period of time. But we have a problem here, right? The problem is that the patient safety world is moving along, but probably not as fast as we all would like because it's very complicated. There's not a standardization element, and we need to train people to do more with less time. And so the question is, can simulation, in the way that I've described it to you, help to do that? And if it can help to do that, the answer is it can. The question is, well, why? Well, why is that? And so here's what we call the circumplex model of emotion. This is many investigators, including Russell and Feldman Barrett, have written and described some of this work. And this was originally tools in, as best I know, the psychiatry and psychology world of many decades ago, where if you were trying to understand what was the most efficacious therapy for someone who was depressed, depending upon whether they were in Chicago, New York, Miami, Paris, London, you needed to be able to understand how people were feeling at any one moment in time over the course of their therapy. And are they feeling one way or the other, better or worse, and in what way? So this was originally designed as a psychiatric or psychological assessment tool, and it's been adopted to be able to describe state of emotion at any one period of time. So if you look at this, it's a 360-degree circle of all of human emotion, or what we call core affect. And so above the horizontal line, right, these are people who are emotionally activated. Below the horizontal line, people are emotionally deactivated. And if you divide it in half vertically, you have the right side, which is pleasant emotion, and then on the left side is unpleasant emotion. So that people who are in the right upper quadrant are happy, excited people. People who are pleasantly deactivated are calm and relaxed. People who are deactivated in an unpleasant way are sad or bored or depressed. People who are activated in an unpleasant way are nervous, stressed, and anxious. So if I took a poll as to the history of higher education, and oftentimes we'll describe this as the quote academy, universities all the way back to Roman philosophers and before, how is it that you think most education was transmitted to be able to do the most good for the most people? Not a critique, it's just the way it's evolved. If you go to any university campus, there's going to be buildings, and the buildings are going to usually contain lecture halls, and those lecture halls are going to be the repository of lots of teaching. So one teacher can teach 100 students. It's fantastic. That doesn't mean that there aren't other modalities, but if I had to ask all of you as you participated in the educational paradigm that we consider to be grade school, high school, college, typically, in the mass conception, how do people feel for the most part when they're going through those experiences? And if you're not sure, right, then if I took a picture of you and showed it to you, then you'd be right on target. So where do you think all of you are sitting here? Be so bold as to say that.
Pleasantly activated.
Yes. Well, so if I had to draw a circle, I would say that the circle is kind of like in the bottom right quadrant. There are some really cool people who are activated and they're like, let's go. There are some people who are like, dude, I've heard this before and I'm kind of pissed. Those people are up here. And a little bit of the people up here are kind of irritated. Some people are, but everybody's like, whatever. Gordon's a nice guy. It's okay. I got, I had a nice time at Harvard Gardens. Whatever. Right? So you're all sitting right down here, or we're lucky we got a little other pieces of the quadrant. And that's a routine reaction. It's not good or bad. It just is. In the simulator-based world, right? We think that 4 out of 5 people are about here. If I drew a circle, it'd be right here. It's above the line. It's not all the way up here. People are freaked out and too nervous, but they're kind of here. And you can see that in videotapes of simulation because people are laughing. They're a little nervous. They're a little excited. Some of them may be a little unhappy that they're there, right? So it doesn't matter where you are, if you're a little stressed or you're a little excited, but it does matter that you're up here, right? And the reason it matters is that you're up here because that is more of a replication of real life emotion than being down here. And when you are up here, you learn in different ways, not better or worse ways, but different ways. So if I asked you all to remember the 5 most important things that ever happened to you, the chances are that you'd be in this above the activation phase, and it's very memorable. Way up here is where people can have such traumatic experiences that they have trouble managing. And the goal of the simulation activity is to move people into a mid zone where they're activated, but not so activated that they can't learn or that there's going to be negative outcome from their exposure. And so simulation, we think, works because it puts you here, but it puts you here in a safe environment. So it's risk-free, and yet it gives a power to the learning that can't be had here. Not good or bad. These are two different emotional states that would contribute to learning. And so if that's really true, right, if I can create an emotional state that is safe, that is enjoyable, and or again, some people will be a little nervous, but it's not a negative experience. It's usually viewed as a positive experience, but it's activated. And if it's true that being in that activated state allows you to remember, process, think in a different way, then this becomes the question of can this kind of learning with emotional engagement do anything for the traditional learning curve? This is the traditional learning curve. And so this is expertise over time. It's stepwise, and it's designed to be able to protect patients. I can't put a novice in an advanced clinical ICU because they just don't know enough to be able to be safe in that environment. And they only get safe until they go through all these steps. And these steps take a lot of time and years. And we have time and we have standardization issues. So the hypothesis is that simulation can do something like this, is that it can replicate the clinical encounter with enough valence, emotion, to be able to allow you to process information sooner, quicker, more efficiently, so that you can accelerate the development of expertise, but at zero risk to the patients. Because in the real world, the way that you get this experience is you just keep practicing over and over and over again. You get really good at it. But when you're at the low part of your training curve, you may not provide as good care as when you're at the high part of your training curve. That's one of the things that we've been trying to address for many years, and we think that simulation might be able to help with that. So I gave you both definition of terms, kind of the philosophical approach to how and why we might engage in this technology, because we don't want to engage in the technology just because it's interesting. And it turns out that now this is a paper that was written about 5 years ago, or more, it looks like. But this was summarizing 20 years worth of scientific work ranging from randomized control style studies to others that make it quite clear that if you engage in this kind of practice, patients will do better, right? And that's true across domains. And it's a rarity in the educational space. It's very rare to be able to say, if you do this, then we know that your patients will do better, but it's true, right? And now it's been 30 years worth of data. So now the question becomes, if you know that it's true and it improves patient outcome, how is it that you can scale this activity and make it so that it's available to as many people as possible? Because it may hold the keys to helping the healthcare system to understand how it can be more efficient, more effective across a workforce and across a patient population. So this has been sort of the history of kind of simulation as it's evolved into the world of the science, both behaviorally and in terms of outcome studies, so that we can get to the point and say, boy, training in this way makes perfect sense. It addresses problems that we have, and we know that it works. So then the question becomes, well, what do you do next, right? And so my answer to this is usually, we got to get it to more people, right? And so this is a scaling exercise that we begin to do at Mass General and across the system to create environments where more and more people can be exposed to things that we know will improve care and that they will actually improve people's workplace engagement as well. I'm going to give you one little detour here. And we talked about education to improve care. This is teaching and learning. There's another sidebar here, which is it true that you can use the simulator to evaluate performance? And the answer to that is also true, right? Because in the old days, lots of people were watching you do things. This was not very sterile and it was not very private. It's a plastic dummy, so we could put people in all these seats, not a violation of privacy or infection control. But we've gotten away from having 25 people watch what you're doing. And having 25 people watch what you're doing, you know, it has its challenges, but can be really helpful in getting feedback. So the question is, how do we begin to get people more feedback? And can we understand whether if the work that they are doing in the simulator world is predictive of the work that they would do in the real world, which allows us to understand how learners are doing along the way, how they're progressing, what their competency-based assessment looks like. Because right now we have time-based education. Your program is 5 years long. But wouldn't it be great to be able to say, you graduate your program when you know what what the outcome is supposed to be? The hard part has been, it's always been hard to assess how we know that. And the simulator, if it's realistic enough, gives you the opportunity for that. So simulators, if you put people in the middle of not a teaching exercise, but they walk into the room with the simulator and the simulator says, doctor or nurse, I don't feel well, can you help me? When this is video recorded and scored by an expert, you can understand, does this person know how to take care of childhood asthma? Does this person know how to be able to put somebody to sleep in a difficult situation in the operating room? Does this person know how to be able to handle and marshal a team in a trauma case? These things you can videotape and show to experts in ways that you couldn't do before. We think that the simulation world allows you to see dynamic decision making, it's easily observable, and it's a better representation of what we'll call reality, which is different from your paper and pencil answer on a test. If I asked you the question of what's the right drug for this particular condition, you probably will check the box that's right because you read about it. But if I watch you practice, I want to know, are you going to order that drug? How quickly are you going to order that drug? Is the patient allergic to that drug? Do people agree that it's the right drug? So you can do great on your test, but what I really want to know is what you're going to do, right, in practice. The problem here is that looking at a plastic simulator is not like looking at a patient, right? A patient will look you in the eyes, will have a pallor or sweat or flushing, and you'll be able to sense, the good practitioner will sense, patient is doing well, patient is not doing well. I can't do that in the simulator. But what I can do is to notably change the presentation so that it's not a nuanced presentation. And so, for example, if I said to you there was a simulated case in which somebody came home from college and they have a fever of 103, and there's an outbreak of meningitis in their school, and their head hurts and their neck hurts, and they show up and they say, God, my head hurts and my neck really hurts, and my heart rate is up, and I have a fever of 103, and my roommate has meningitis, right? So, okay, great. That's not a mystery. I've taken away the ambiguity. Now I want to know how you treat this, right? Show me what you're going to do. Show me how quickly you're going to give the medication, what kind of tests you're going to do, who you're going to call, how you're going to describe it to the patient and the family. I can't get that out of paper and pencil usually. So I can correct for the disadvantages, but it's not perfect, right? It doesn't look like a real person. We did some early work to be able to understand whether it's really true that you could assess people in a simulated-based environment and that the metrics of whether or not your score is really representative was true. And so if you look at this graph, this is essentially taking a test using a standardized patient, and this has been well validated by medical and nursing boards. You have an actor patient who walks into the room and you examine and treat them. The tools that we use to grade or assess that are pretty well studied. And if you use those tools in a simulator-based environment, they perform similarly, which means it's not a mystery to evaluate and tell the difference between a student, a house officer, and a more senior chief or fellow. The tool of evaluation will give different scores to each of these groups, and that mirrors the work that's been done before, which means it's not beyond our reach to be able to understand whether your performance in a simulator-based environment using a testing tool will be discriminatory. And this was also work that was done in the early days of work hour restrictions, because many of you know in the US healthcare system for MD trainees, you can't work more than 80 hours a week because it used to be 100+ hours a week. And that was because people clearly could identify that when you start to work over 80 hours a week, you're too tired to be able to do the work that you could do better when you're awake. And so this is a study that basically, this was the early study in the New England Journal in 2004 that showed that in the, if you take somebody who's rested and then you sleep deprive them, their score on a standardized assessment of clinical performance goes down. This person was rested at 6, they went down. This person was rested at 6.1, they went down. So that's what ushered in the era of 80-hour work weeks. Patient safety imperative. You got to get enough rest. This is why pilots don't fly 24 hours, right? They got to take some time off. We replicated that and we used the same study protocol, but not in the real world. This study in the New England Journal, real world. They had actual people following around the interns 24/7 and writing stuff down. Oh, they were supposed to draw blood from the right arm and they drew blood from the left arm. Things that they could quantitatively say, they're supposed to do it on one way versus the other. And we did the same thing in the simulator lab, and not surprisingly, it looks the same, right? Is that when you're rested, you do better than when you're sleeping. But that's not surprising. But if you translate that, it means that it really is likely true. Well, I shouldn't say likely. There is a correlation between how you do in the simulator and how you'll do in the real world. And that means that if you put people in a simulator-based environment and you test them, it's very likely true that you can assess and predict their clinical performance, which means that you can move towards not you just have to have 5 years worth of training, but you have to have enough training until you get to the point where you feel that that your instructors feel that you have competence. Okay, I'll spend the last time sort of wrapping up to be able to say, we've described how simulation can be used as a teaching and education tool, some of the theory and science behind that, a little bit of how if you go into the simulator-based environment, you may be tested and evaluated and what policy implications that have. And so now we have a body of evidence that suggests that this kind of work is really important and effective, not just because we like it, but it's shown to be effective scientifically in patient outcomes and other kinds of outcomes that we care about. And so at MGH, we've begun to invest heavily, along with partners across the system, in understanding how education, which is oftentimes viewed as a cost center, people view education as costing time and money because the trainee needs time to learn. The doctor or the nurse or the technologist has to take time to explain to the student or the trainee how to do something. So the theory is that the training enterprise slows things down. And it's really true that in the teaching hospital, my experience has been that it is such a remarkable value to the community in a whole variety of ways, such that we think of education not as a cost item, but really a value proposition. And one of the ways it does that is by binding together a team that's working together to be able to provide new science in the middle of a community that's engaged. And the way that we think about this is the value proposition here is it is likely true that better education yields better care, which yields better outcomes and a better system. So at MGH over the last 10 or 15 years, we've begun to understand how could we take what is now evidence-based intervention and put it into practice. And you see that there were two pieces of this strategic plan: integration across teams, not just doctors, not just nurses, not just pharmacists, not just social work, all together, integrating the teams and working at scale. So interprofessional education and routine practice in the medical environment. In order to do that, there were two elements that were invested in. One is what we call Academy. Now we call it the Slavin Academy for Applied Learning in Healthcare, right next to the Ether Dome. This is now a 5,000 to 6,000 square foot space that we can call home for education and educators at Mass General Hospital and across the system. And this is where the educators and the teams who support a teaching hospital, which is just about everybody in the teaching hospital, can participate as part of the educational activity. You'll see here that it has a research component, a teaching and training component, innovation component, and an infrastructure component. And you think about it almost as educational planning and evaluation. And this has just been recently built, and I'll describe it in just a second. And then you need a place for this staff and faculty to be training people offline to be able to understand how you can apply some of these practice and experimentation methods for feedback, which wouldn't be safe in the real environments, but are quite safe in the simulator-based environment. And this is considered a build-out of a training facility called a learning hospital. In this case, we're fortunate that the Lunder family has been so generous with their support over many years at Mass General. So this will be called the Lunder Learning Hospital, and this is the Slavin Academy after Peter Slavin, our president of over 2 decades, who has retired from that spot. This is to be built as the 2 new towers at Mass General on Cambridge Street go up. So it's a little ways away, but we're beginning to forge the infrastructure for that moving forward. And this is what the infrastructure looks like. This is 2 elements that were part of the wonderful gift from the Lunder family called the Lunder Learning Initiative to build out the Peter Slavin Academy for Applied Learning and Healthcare. That was just completed in September of this year. And this is now on the planning slate to be able to be built, a 20,000 square foot replica of a hospital that allows multiple wards, units, and teams to be able to practice together at the same time so that we can provide more and more activity. We can scale this training activity across the entire workforce to then help us answer the question, if we do make sure that everyone in the hospital is able to practice on a more routine basis, does it change the quality and safety profile or the experience of being in the hospital? So the Slavin Academy has been launched over the last few years. You can see the history of Harvard and Mass General. This is Mass General Hospital on the River in the mid-1800s. This is Harvard Medical School right across. This was here, I think, for about 50 years, and Harvard has moved a variety of different times, but now in the Longwood area, where you see the building that was built in the Fenway Fields around 1910 or 15 or so. But Mass General built in 1821 and founded in 1811, remains right by the Charles River. You can see that the backfill, right, of this, the river now is a few hundred yards away, but you used to be able to get to the hospital just by floating down the river. And then you see this is Boston Slavin Academy's inaugural kickoff meeting right next to the historical State House. And so there's been a long history in Boston and Massachusetts and Mass General and affiliated systems in the Harvard community of working hard to be able to improve care through education and research and great practice. And you see their vision and mission statements here, which are quite broad, to be able to harness education to transform healthcare and to work as a community to improve patient care across an entire workforce. If you visit the MGH campus, and you're all certainly welcome, the Ether Dome here is what you see me circling up here. This is the Bulfinch building that was built in 1821. This was designed by the same architect, Charles Bulfinch, who I believe was either born or lived up the street, who designed the Capitol, the US Capitol, or a version of it. And so this entire wing that is right to the east of the Ether Dome is now Slavin Academy. And you can see it has, oh, there's Gabrielle, a replica of Ether Dome to be able to sort of bridge old and new into a home for education. So we're excited that we're off and running and eager to welcome people at any time, and certainly happy to answer any questions. I think I'm getting close to the time.
Thank you so much. Zoomers, if you have any questions, feel free to type them into the Q&A. Since I have the microphone, I'll start with a question, which is, I've always been fascinated by the idea of these debriefs after a simulation. Can you talk more about what exactly those entail?
Okay. Yes, so thank you. So some people, and including my mentors and colleagues, would say that simulation is just an excuse to be able to bring people together to talk and learn together. And I think in many ways, the great power of simulation is to be able to do that, is because we oftentimes lose the opportunity to share ideas and thoughts about what's going on about a particular case, in part because we have to go to the next patient or go to the next patient, go to the next patient. And at the same time, there's an inherent value proposition to practicing, right? To touching and feeling and sensing. But both of these things are hand in glove. You can't have one without the other. So I can have a great conversation in a morbidity and mortality case conference, and that'll be really instructive. But is that as good as if I participated in the case myself from a learning exercise? No. Can everybody participate in that? They can't. Can you get closer to that real experience by simulating it? You can. So it's kind of a combination of being able to bring people together and to talk and share, but also to have, everyone should have the emotional experience of being part of the care team, which is very hard to do when you're lecturing.
Any other questions from the room? Right.
Okay, well, it's been a delight to see everyone, and I look forward to seeing you on campus.
Thank you so much. All right.